Well, it is 4 o'clock, so we will go ahead and get started. Good afternoon, everyone, from my cold, snowy home here in northern Montana. My name is Caitlin Conway, and I am a chronic disease and patient family engagement senior account manager here at Mountain Pacific Quality Health. I want to thank you for joining us for our first session on COVID-19 and diabetes, empowering the patient. In our 4-part learning event, we'll discuss the impacts that COVID-19 can have on prediabetes, diabetes, and chronic disease management. Our plan is for you to participate and engage in quality improvement activities designed to engage our patients in diabetes self-management, improve clinic policies and procedures, and identify needs for improved patient outcomes. The subsequent sessions will be on November 3rd, November 17th, and December 1st. Today's session will begin with a wealth of information about the current situation. I'm happy to welcome back Stevie Tsai as one of today's presenters. She's been with us here at Mount Pacific since 2017. She currently works as a healthcare transformation account manager, and she leads projects in Wyoming that work to reduce adverse drug events. She works very closely with various partners in the state to share knowledge and increase participation from pharmacists and primary care providers in quality improvement projects. Joining Stevie today is Kyla Newland. Kyla graduated from the University of Wyoming School of Pharmacy in 2007. She has additional training in ambulatory care pharmacy with certifications in cardiovascular risk assessment, diabetes, medication therapy management, and vaccinations. Kyla works on several patient safety initiatives, including reducing adverse drug events, opioid safety, and chronic disease management. She also works as a community pharmacist. Welcome, please join me in welcoming Stevie and Kyla.
Thank you, Caitlin.
Thank you so much. Thank you so much, Caitlin. We appreciate that introduction. I'm going to kick us off today with our COVID introduction. This is Stevie. Kyla, if you could hit the next slide, please.
I'm trying. There we go.
There we go. All right. So if you joined us for our hypertension series, this 4-part session is going to feel very similar to that. We're going to highlight COVID-19 related current events in healthcare. We're going to talk about best practices for diabetes identification and management, particularly during this pandemic. And then we're going to work on implementing quality improvement projects to improve diabetes diagnosis and management and engagement and empowerment of patients. Next slide, please. Here's a reminder of who is in our region at Mountain Pacific Quality Health. We are here to serve in the areas you see on the screen. If you happen to be located outside of those areas, that doesn't mean that we aren't able to support you. We just also will probably connect you to someone who works locally in your area as well. Next slide, please. So that will move us into our COVID-19 regional updates. As you can see on these slides, things are definitely moving. This mirrors what's happening nationally. In Alaska, we have 200 new cases as of the 19th. That brings their total active cases to just north of 5,000 people. I've started including hospitalizations on here as well because capacity is becoming more and more of a concern for many of our areas. The test positivity average, that 7-day rolling average, continues to climb in most of our region. Alaska is no different. So we are seeing that to start swing up again. I have seen some news that this means we're moving into the second wave of coronavirus infection. We never exited the first wave. So this is just a continuation per national epidemiologists. So things to consider. Guam has been making the news quite a bit for their coronavirus outbreak. Unfortunately, they are in the top 5 locations in the nation for new infections per 100,000 people. So they have seen many, many new cases, and they are seeing more and more hospitalizations, and unfortunately their death toll is rising as well. Next slide, please. Hawaii is our bright spot in our report today. They were able to really crack down on the transmission of coronavirus through re-implementing some social distancing and stay-home orders, and that has been successful there. They are seeing their number of new and active cases drop dramatically. People are getting to leave the hospital. Unfortunately, we are still seeing the death toll rise in Hawaii from their large upswing that they had in August and September. But their test positivity rates and those things continue to drop, which tells us that they are reducing that transmission pretty dramatically. Montana is on the opposite end of that spectrum. They are also in the top 5 for new cases per 100,000 people in the United States. They had 706 new cases as of yesterday, which brings them almost to 9,000 active cases, which is very high per capita. We have seen many deaths as a result of this, many full hospitals. So again, capacity is becoming a concern and indicates that perhaps we might need to do more to slow the transmission. Next slide, please. The Northern Mariana Islands are hanging in there. They are continuing to average 0 to 2 new cases per day. They've had a couple of days where they are spiking at 6 cases, but they are holding steady very well. They've only had 4 cumulative hospitalizations since the beginning of the pandemic, and they have just 2 deaths. So they are another bright spot, as is American Samoa, who has still not made our list because they still do not have a case of coronavirus in their borders. Wyoming is right behind Montana on their upswing. Most of our neighboring states in the Montana, Wyoming, South Dakota, North Dakota, Nebraska region are all seeing this large surge. There was some geographical differences when we saw coronavirus first hit the United States, where it was hitting urban populations sooner. And we saw dramatic upswings last spring. Now it seems like we have moved into those more rural areas. So the Wyoming, Montana, Dakotas, Alaska, all of those places are definitely being harder hit at this time. Still not quite sure why that would be, but again, our per capita rates are pretty high. We have a high number of hospitalizations, and our 2 largest medical facilities in our relatively rural state are at capacity. So this is becoming a big deal in Wyoming. Next slide, please. This is just a nice snapshot for everyone to see those per capita rates so that you can really see the daily cases. All of these are per 100,000 residents so that you can sort of compare apples to apples. The number of active cases is pretty alarming in Alaska, Guam, Montana, and Wyoming. It's very important to keep those people in an active quarantine and isolation situation so that they're not able to continue to spread the virus. Unidentified active cases are typically a source of community transmission where they're able to perhaps touch a hard surface and then someone else picks up the virus, but more often than not expose other people to their respiratory droplets or an aerosolized virus through coughing. So things to keep in mind to keep all of those things low. And then you can see that the deaths per 100,000 are really, really hard hit in Guam and Montana. Wyoming and Alaska are following along with that. Hawaii did see that peak when they were having their surge. Thankfully, they're coming out of that. Unfortunately for Alaska, Guam, Montana, and Wyoming, where we're really still seeing things swing up, we can expect those numbers to climb. And if we don't keep a good handle on hospital capacity and going back to bending the curve and slowing transmission rates, we'll see those deaths increase because obviously we need hospital beds to be able to keep those critically ill patients healthy. So no real sunshine or rainbows in our COVID report today. We are at the beginning of influenza season as well. Our isolation and social distancing precautions can really help reduce the risk of influenza as well. It's important to right now get people in to give their flu shots so that hopefully we can prevent a dual pandemic as we move further into the fall. So that is it for our COVID update today.
Thank you, Stevie. So this is Kyla, and I'm going to talk about how COVID and diabetes are related. I'm going to start with some questions that we asked when you registered for the webinar, finding out what you're concerned about as you care for patients during the pandemic. And we were seeing basically what we've kind of seen in the research here, that every healthcare providers are worried about folks with chronic conditions not seeking care because of fears during the pandemic and really not having their disease state managed as it should be. And so you mirrored that in your responses. And I was really happy to see the results of this question asking about what you'd implemented to help support chronic disease management, and seeing that 45% of you have increased referrals to lifestyle programs, which is something that Mountain Pacific is working on actively doing to support in all of our states. And so that was really great to see, and we look forward to being able to support you moving forward with doing that. So just a little background on the burden of diabetes. So 1 in 10 Americans have diabetes. Something that was pretty alarming to me when I saw that number is that 7.3 million of those are actually undiagnosed. So that's a huge percentage, and you'll see that too with the number of patients that have pre-diabetes. And I'll talk about that on the next slide. So important for our states is looking at the 14.7% of cases are in American Indians and Alaska Natives. So that's a huge consideration when you're looking at the populations in our states having a high amount of those folks. And then many of these people have some kind of kidney dysfunction already as a result of having diabetes and not knowing it. So that's also something that is one of our kind of top priorities and initiatives as far as preventing chronic kidney disease and preventing advancement of kidney disease. And then if you look at the percentage of folks that are overweight with diabetes, it's a huge percentage. And we know that COVID folks that are in the obese range are also at increased risk of severe illness if they get infected with the virus. This is something I took a look at that might be useful for just as a resource if you want to look at your state. It is a little bit outdated, but this is self-reported prevalence data, and it's a really nice interactive platform that you can use to kind of take a look at what's going on in your state. I pulled data from Alaska here, and as you can see, the age range where we typically see the most cases of diabetes being reported is in 45 to 64. And if we look at the age at which we start seeing increased risk for diabetes and pre-diabetes, it is around the age of 45. So 1 in 3 Americans actually has pre-diabetes currently. And you can see here the risk factors for pre-diabetes. And that's where promoting the diabetes prevention program as well as disease state management programs is really important, and something that we want to work with you to promote and help you get your patients access to those programs and get them referred there if they're appropriate candidates. This slide is just highlighting that we have higher rates of diabetes in our Hispanic and non-Hispanic populations. Just another thing to consider when we're looking at folks that are increased risk. And we know that their risk actually starts at a BMI of a little bit lower than the normal population at a BMI of 23. So that's just something else to keep in mind. I'm just waiting for my slide to advance. I'm sorry, you guys, my computer isn't responding. Give me just a second. Turn off my camera, Maynette says, or Mary says, let me do that. Oh, I think I went too far. Okay, so we're on to polling question number 1. We just want to find out, and these polling questions that we're doing today are really to try to develop the material for this series moving forward. So Mary, if you could pull up that first polling question, thank you. All right, I'll give you just a few more minutes. It looks like about half the folks have responded currently. All right, so it looks like about 50% of folks have already have an established protocol in your practice, which is awesome. I'm going to turn off my camera here. I'm having trouble advancing the slides. Must be my internet in Alaska, you guys, I'm sorry. I'm just going to move on with the content and hopefully my computer will catch up. So when we talk about the intersection of COVID and diabetes, we know that patients with diabetes already have a higher risk for infections, including respiratory viruses, including some of the viruses that we've seen like H1N1, the first SARS virus that we saw in about, I think that was 2013, and then the MERS virus. So there are some proposed mechanisms that why people with diabetes are more at risk for these viruses, including the fact that they may just have chronic inflammation, increased coagulation activity, immune response impairment, and potential direct pancreatic damage, which I think might be something that Stevie might touch on earlier or later. So we know that patients with diabetes often have other coexisting chronic conditions. And as we'll see on the next slide, if we add these chronic conditions together, the increase for COVID kind of becomes a cumulative effect. So you guys have probably seen this. I know we use this in our previous presentations. It basically just shows that cumulative effect for patients being at higher risk of hospitalizations with basically additive chronic conditions. So you can see here that if someone has 2 chronic conditions, they're actually at 4.5 times higher risk for having severe ramifications of COVID-19. And this kind of just reiterates that fact for us. The next slide is coming up, sorry. I took a look at a study where they looked at folks in China and looked at composite endpoints for risks of poor ramifications from COVID-19. 10 to 20% of these patients had diabetes. And really we saw that the more comorbid conditions somebody has, the worse their prognosis. Okay, we are going to do polling question number 2. So this is actually both questions will come up, but we actually have 2 separate slides. If you just answer number 1 to start off with. And then to answer number 2, we'll have to have you scroll down to see all the options. So for number 1, we basically just want to find out how you guys are looking at data from your EHR currently and how we might be able to help you do that to identify patients that are not being managed adequately or might need a little bit of extra support with managing chronic disease. So it looks like many of you, I guess we can probably end the polling. Many of you are already tracking these quality measures, which is awesome. And it looks like a large percentage are looking at A1C levels. Next slide, please. So if you're not already tracking any kind of measures in your EHR or otherwise, these are some suggested ones that we can help you look at or help you extract from your EHR. As you notice, some of these are clinical measures and other ones are really looking at patients that are managed for their chronic disease management or being referred or receiving additional support as far as their disease management, like self-monitor blood pressure, lifestyle classes, or participating in shared decision-making. Next slide, please. And then this was a risk stratification tool that I found. So as far as identifying these patients, you can identify them looking at data that you extract from your EHR, or I thought this was a unique way to really assess patients in kind of their zone as far as level of disease management. And it takes into account not only some clinical measures, but also a depression screening score. So this might be a useful tool and something that I would be curious to see if anybody is currently using anything like this to really look at their patient profile and see how they're doing as far as managing their chronic disease. Next slide, please. So we want to find out as far as moving forward to our next session in this series, if you're currently prioritizing your patients, and then how you're doing that currently. All right, I give about 10 more seconds. So it looks like about half of you are currently doing this. So that's awesome. And it looks like some are using the most percentage are doing looking at a care team management as well as diagnosis codes. And this is something as far as diagnosis codes that I'll just mention, something that we would like to see more of is being able to identify prediabetes patients based on diagnosis code. And that's something that I think probably needs improvement in many many places. Next slide, please. So just to kind of wrap us up and lead into what our next session will be focusing on, I wanted to talk about patient engagement and how beneficial it can be for patients to manage their chronic disease. There's some controversy and there's some data that shows it's not effective short term, but this particular self-management program was really long term. It was a 2-year program, and patients saw really significant increases in end goals for their disease state management, including glycemic control 1 year after they completed the 2-year program. And the difference they saw in that 1-year follow-up was a percentage reduction in A1C of approximately 1%, which is really significant, and it's similar to what we see with our drug therapy that we use. So now we would like to get some feedback from you as far as questions you might have, things that you're doing in your practice. Oh, sorry, Stevie. I think Stevie was going to talk about one last kind of current event item.
Yes, thank you, Kyla. I'm just going to chime in real quick before we move into sort of our interactive portion. With the data that we are collecting around COVID-19, both in the United States and worldwide, we have seen an interesting relationship with diabetes and COVID-19, like coronavirus disease manifestation. So this is a little snapshot that I pulled out of a report that comes from India, but we're seeing case studies and small reports popping up all over the world where we are seeing what is likely a correlation between diabetes and COVID-19. Our emerging data seems to suggest that new onset hyperglycemia is observed, especially in admitted patients with COVID-19. And those folks often had no history of glycemic dysregulation before their disease. They're not on corticosteroids at this time. And so this is something that does seem to happen with other beta coronavirus illnesses. So things like SARS and MERS. And it's likely because the beta cells in our islets and our pancreas are being attacked. We know that coronavirus attacks epithelial cells throughout our body, and beta cells resemble those in a lot of ways. And so there is likely a correlation there, and there is a national registry, an international registry that is now being developed. It is called the COVID-DIAB project, and it's looking internationally to see what the COVID-19 related diabetes impact might be. What we're seeing is basically an autoimmune response to coronavirus infection that can lead to type 1 diabetes. Obviously, this is a new event that is occurring in healthcare, and so we're not sure what capacity those folks have to recover, what longitudinally it will look like for them, but it is possibly an outcome that we can expect for some patients that have coronavirus infection. Of note, hyperglycemia with or without a diagnosis of diabetes does seem to be an independent risk factor for more severe COVID-19 infection. So whether or not they are full-blown diabetes or just pre-diabetic ranges, doesn't seem to make a huge difference. Those folks are at an independent risk for more serious COVID-19 morbidity. So food for thought as we move into this. Now is a great time to help people get to goal because it could possibly improve their outcomes should they become infected. So now we are going to move into our part of our webinar series where we're hopeful we can get feedback from you. I see that Anita has typed a couple questions into our question and answer section. Kyla, would you like to go ahead and answer those for her?
Hi, Anita. So you're wondering about what assistance Mountain Pacific can provide if you don't have an EHR. I'm thinking that Patty might be able to answer that. Is that something you can speak to, Patty, with the work that you've done in Montana?
Sure. Thank you. So some of the work that we're doing, we work with clinics on all levels of whether they have an EHR, or they aren't using it fully, or they don't know how to print out their quality reports. So we can help throughout that whole cycle. And a provider who isn't using an EMR, there are other ways to get data that you can use to identify gaps in care. So we would probably want to talk to you about your specific situation, but we certainly could do that. Anita, I'm not sure what state you're in. If you want to put that in the chat, we will make sure someone reaches out to you and we can identify how we can help you more specifically.
Thanks, Patty.
Yep.
Perfect. So as you can see, Kyla and I do have a team that is behind us right now, ready to answer your questions. During our last 4-part series, we never really got to the sharing part where we could engage with each other. So we're going to work on promoting everyone to panelists so that you can come off mute and participate. And we have a few questions for everyone in the audience. So just a reminder as we move people to panelists and things, this is what it looks like we're most concerned with during the current pandemic. We're worried that people are having worsening chronic disease, they're not seeking care, we're not seeing people for those routine follow-up and their procedures and labs, or they might be delaying care. Those are really our big concerns at this time. So with that in mind, does anyone want to be brave and share? Has your practice changed the way you manage patients with diabetes, with chronic disease, specifically diabetes, due to COVID-19?
I also wanted to let you know that we are promoting you all to panelists so that you can have the opportunity to turn your own microphone and you have the option to speak, or of course you can chat as well, but utilize that function now that we've promoted you to panelist.
Hey, I'm gonna, this is Patty. I'd like to call out Joe if you are on. I'm looking in the wrong place. So Joe Tabler from KRH, are you still on? I'm not seeing him in the patient list. Would anybody like to share what you're doing at your location? So the biggest concern, or some of the biggest concern, was that your patients with your high-risk patients, specifically diabetes, are not getting the care they need. Would anybody be willing to share some of the things you've done in your practice to make sure that happens?
I can share what's going on in Helena, Montana. And a great deal of it has to do with using telemed or phone follow-up. We always use some phone follow-up depending on how busy we were actually to get people in. But at this point in Helena, phone coverage has become more important just as a connection. And people, especially some of our elderly patients, are alone and they really relish those calls. So it hasn't been as difficult as it might sound to people. It's again, finding the time to do what you want to do with your patient, even if it's a check-in by phone, it can get lengthy. So that probably is a constraint. But if we had a better system of well-educated volunteers, I would highly recommend more phone. And especially we know our patients, or we can see their ages, knowing that some of them are so alone.
Thank you so much for sharing that with us.
Yeah, I'm not sure who was just sharing that, but I would like to ask a question of that. How are you dealing with telehealth medicine, telehealth calls when technology might be challenging for the person on the other end?
That, and I'm actually Carrie Fairbrother. I will be one of your speakers later, so I'm just been enjoying being on, but when nobody wanted to say, I thought, well, I'll tell you what we're doing here. It is a problem. We are lucky because Helena has probably more per capita uses of smartphones, et cetera. So we have been able to, otherwise we've been using purely telephone, and reimbursement would be an issue that many of us can talk about. So that could be a whole different talk, but that if you don't mind having low levels of reimbursement, that's why I mentioned the volunteers, potentially a good group of volunteers, then you're not as concerned about being reimbursed for the call. And I'm actually speaking to even getting people to be able to say they're not taking their medicine. They know they're eating bags of chips right now. You know, it doesn't have to be so technical. It's more, as we talked about, behavioral.
This is Cassie in Glendive, Montana at Glendive Medical Center. I'm making sure, can you hear me?
Yes.
Yep.
Okay, perfect. So we have an older, I've made a comment in the chat box. We have an older population here in our small community, and we have moved a lot to telehealth. And one of the things we did to help is we have a really good IT team. So when our patients can't get in or get on their mobile phone or whatever it needs to be, our staff are able to remote into their devices from their home and assist them, so that, like the other person was saying before, we can see and hear them, because seeing and being able to hear them at the same time is a much better reimbursement. So we've done that. And we've also moved, you had talked about earlier, our outpatient lab was in like the dungeon, or is in the dungeon of our facility. And so we actually moved an outpatient lab right outside our door, so that patients don't have to be in our building for a very long time. We were told it makes them feel a little bit safer. So we've tried to relocate that to a more on the edges location for us. So those are just a couple of things we've done.
It's Joe Tabler here in Kalispell. I don't know if you can hear me now. Am I getting through?
Yep, we can hear you.
Okay, I figured out technology. As was mentioned before, we're at our one clinic, we're using a fair amount of telehealth. And the other thing I've found that seems to have helped some of these patients is to not just worry about their disease state and worry about what their numbers are, is I try and empower them with the phone, as well as get them out and do some physical activity at the same time, because some of them are so cooped up, and you have to tell them that just going out for a walk around the block or two is going to help them out. And I've been trying to instill lifestyle modification along with this at the same time as doing the phone calls, because I think it does them good to get out before the snow hit.
Hey, Joe,
Yeah.
what results are you seeing?
Right now, I'll just give an example. This morning, I bought one lady that's in her late 80s who was diabetic. We tried a lot of oral stuff on her. It didn't work. So I've got her onto insulin, and she's actually managing on her own now after a fair bit of education. And she said one of the things is letting her do the stuff herself has really helped her out. As well, she said she thought that she was too old to worry about exercise and so forth. So we're actually seeing her, our last A1C, since when COVID started, she had an A1C in the 9s, and now we've got her an A1C down into the low 8s. So I think we're making some progress with some things like that. And I think one thing COVID has done for me, it's made me want to make the people more empowered instead of babysitting them and having them come in all the time. It's made me tell them, you've got to take care of yourself and do some of the stuff yourself. And, you know, because we don't have the time to do everything one-on-one anymore on the telephone. And it just seems to, some of the patients has done a good job of making them take control of things.
Great. Great job on helping reduce her A1C too. Nice work.
Well, she was ecstatic this morning when she found out what it was. She just, you know, she was one that took a bit of education, but I think there's the mental health side of it too. And I think whenever we think about this, we always just think of what our numbers are, but I think we got to think of that whole person, because nothing is as debilitating to an elderly person or even somebody younger than me that is struggling at home and you're locked up all the time. And all you got to do is think about yourself. And if you think about COVID as a whole, what's been the thing everyone talks about? Oh, I had the COVID 25, the COVID 40 and everything else, which doesn't help us control diabetes by any stretch of the imagination. And if you listen to radio shows, all they talk about is what you can cook while you're at home in COVID and so forth. So it was, I think some of the radio stuff has been negative too for that.
Well, great. Thanks for sharing.
Yes, thanks for sharing. I thought it was particularly important, the piece you mentioned about how this is sort of encouraging us to help empower patients. The time is really right to sort of have those big shifts in life. Everybody is working through change anyway. And I think that's encouraging that it's working so well for that patient. Congratulations.
It's not just for one, we're working with a lot of them. And I was really impressed with one thing you brought forward, that Indian study that showed about basically the autoimmune side. And that made me trigger back to working with an endocrinologist about 6 years ago, who had done a small scale study on people who suddenly turned type 1 in their late 20s, early 30s. And it seemed to be some connections to, and I know this isn't going to be political correct right now, the study seemed to correlate to certain flu vaccines that they were getting. And the autoimmune response that was mounted basically triggered them into type 1s. And that group that she was reporting on, absolutely no one ever came back.
Yeah, that would be interesting. Yeah, so for better or worse, we do know that type 1 diabetes is an autoimmune disease. And so there are definite components. And I think lots of people have held suspicions for a long time that it does seem to be related to some sort of viral illness trigger in a good chunk of people. So unfortunately, I think that is a lifelong issue that some people might walk away from the COVID pandemic with. It is definitely a concern.
And I think one of the things, and it's not just, we're talking about diabetes today, and I think we have to look at a lot of our people who, if we could get our charts to give us good BMI data as well, because everything I'm reading lately, as you mentioned before, obesity minus hypertension and diabetes just puts them at an extremely high risk factor.
Yeah, that's when I was doing my research, a lot of the overlap that I was seeing too, and it just stuck out to me.
Hey, Kyla.
And
Whoops.
Go ahead.
Yeah, this is Patty. I just did want to share another success. I had a client who was supposed to join and she just texted me she was unable to do it. But one of the things that they did, what they changed in their practice was they're doing a drive-through flu shots. So their patients don't have to come into the office. They found that their patients were hesitant to come in, but they didn't want them to miss their flu shots. So they focused first on their higher risk patients, but they really opened it up to everyone. So they found huge success in that new workflow, keeping their flu vaccination rates high, and the patients comfortable with the exposure.
Thank you for sharing that, Patty. That's a nice segue into sort of the next question we have for you. What successes are you having changing your workflows or processes to meet patient needs during the pandemic? Much like what Patty just talked about, I know many pharmacies have started implementing curbside pickup where they didn't have it before. Delivery services are becoming more prevalent. We're seeing a lot of creative ways where we're still providing patients with immunizations when they need them. What other interesting things have you tried? Did it work? Was there anything that you tried that didn't work well that you'd like to share? We'd love to hear.
Doing curbside lab testing, like things like your A1Cs, INRs, and so forth, it worked well when the people wouldn't come in the spring, but I think it's going to be a bit difficult in the fall, winter as we're going that way. And I know, like you mentioned, the drive-through flu shots is a big thing because a lot of people don't want to come into clinics. But I think that's one thing we did is high-risk people, we're not forcing them into the clinic. We try and do as much of the stuff curbside as we can.
This is Casey from Hawaii at Queen's Health Systems. So as an outpatient clinic, we're still having patients come in to do our flu vaccines and pneumonia vaccines and whatnot, but our system implemented the drive-through flu, just call it a flu shot blitz, and the outpatient clinics staff were helping with that. So same thing, I'll echo that I think that really has gotten a lot of patients to at least get their vaccinations done.
This is Randall, also from Queen's Health Centers in Hawaii. And I think, one of the problems I have is that we're making it so people are afraid to come to the clinic. And actually, that's probably one of the safest places that they can be. So what we did at our clinic in Mililani and Haleiwa is we started very early on in March, having a good triage. So we try to triage out all the sick people and try to have the healthy people come into the office. And that's worked very well. So compared to national statistics, our drop in office visits was about 20% compared to many other places in the country. And if you look at the contact tracing data out of China and even out of New York, the biggest risk for patients is actually in their home, not in the doctor's office. So if you look at COVID transmission in a healthcare setting, if the patient's wearing a mask, the doctor's wearing a mask and a face shield, the transmission rate is less than 1% in the office. The transmission rate in the home is between 10 and 26%. So even if you look at the data from New York, in New York, when they look at antibody studies, in Manhattan, 20% of the population had COVID. And in Long Island, it was 16% of the population had COVID. If you look at the healthcare professionals, it was 6.8%. And that's when New York didn't have PPE for their healthcare providers. So I think one of the things that people may want to look at is, rather than having people afraid to come to the office, is to make the office safe enough with the proper setups. So things like, it's all what the CDC and AMA recommends. We have triage protocols, telephone triage to screen out people that are sick. We try to see the sick people at the end of the day in a separate part of the office. We have only one person in the room with the patient. We let people stay in their cars and call them in if they want. We make sure that the waiting room is empty, bring people back as soon as possible. But I think the focus should be on making sure chronic diseases take and immunizations and those things take precedent, and trying to keep and for most of the sick people, we're not going to be able to treat their things anyway. So we also came up with a new protocol for flu and joint COVID, anticipating that's going to come up in the flu season as far as when to test, when to have people come in. But I think we need to make people understand that they're probably the safest place they're going to be at is in the healthcare setting.
Thank you so much for sharing that. You are spot on. As long as we are keeping our universal precautions in place, if we are practicing good infection prevention, this might actually be one of the safest times we've ever had in our clinics, because we finally have a little time and incentive to clean and garb appropriately and really keep our patients safe. I'm so glad you chimed in with that, because I do feel like a lot of us have really missed the mark in conveying that to our patients, that not only do we want to see you, but it is safe for you to come in, and we're doing what we can to keep you safe.
Does anybody have any trouble with patients coming in masks, because your location has that as a procedure, but then when they get into the office, proceeding to take their mask off?
We don't have problems with them trying to take their mask off, but they always want to pull it down below their nose.
We take that as an opportunity to educate them. So if a patient doesn't have a mask, we actually will give them a mask. And we explain to them why it's important they have a mask. I explain to them that even if they have COVID, if they have a mask, I have a mask and a face shield. I don't have to miss work. I just have to self-monitor. So I think it's an opportunity to educate the patients on the importance of the mask.
Yeah, I would say to that, thank you so much for sharing, that I think this lends a very good opportunity for us in patient education, as we educate about their chronic disease, as well as, risks of getting COVID and where it's safe, and just an opportunity, I think.
And it looks like there is a question in chat. Any advice to those who are immune suppressed and won't be able to get their flu shots due to an existing medical condition? As an immunizer, I would just remind everybody that those conditions that do prevent vaccine from influenza are pretty small. It is an inactivated virus that is typically used, so they wouldn't be candidates for the nasal, but they could still, in most cases, receive the injectable influenza vaccine. You have to be, pretty vulnerable to infection for us to weigh that risk versus benefit against getting a flu shot. With that being said, vaccine hesitancy is still very much a condition that we are faced with and we're having to deal with. So, motivational interviewing is a great place to come with that, and making sure that you have the vaccine readily available. So if a patient expresses interest, you can immunize them right that moment. And then just providing some of that knowledge about the safety of the vaccine has some limited ability to improve vaccine hesitancy and willingness to be vaccinated. Unfortunately, that is still a major concern for most of us in our clinics, and will probably be something that will continue to be an issue as we move into coronavirus vaccinations.
in fact, for that immune suppressed question, again, we would take that opportunity to educate them and saying, not only do you need the vaccine, but everybody that you have contact with in your family needs the vaccination to protect you. And I actually just had that this morning where I had a patient with ischemic cardiomyopathy from, and he has ejection fraction of 30 to 35%. And initially he refused the vaccine. And I told him that, well, that is not the best. You got to read everybody differently. But my motivational intervention for him was, why did you not want to get it? He said, I don't know. I said, if you get COVID and the flu, you're dead. And then I told him that everybody in his household should get the flu shot too. Everybody around him should get the flu shot. He decided to get the flu shot. And during the visit, his daughter called and he said, oh, doctor said all of you guys got to get the flu shot. So I felt like I was a success today.
That's a huge success. You should definitely celebrate that. It's always good when we not only vaccinate one patient, but convince many others as well. So in our last couple of minutes, I'm going to move us to our leaving in action. I really want to thank everybody for your participation today in our webinar, coming on and sharing your successes. And I just wanted to encourage everybody to do 3 things as we leave together today. I'd like you to reflect on what you learned here today. What's one thing you can go back and share with your care team? Evaluate some of your data sources. Think about those polling questions. See what you have at your fingertips that could help you identify those high-risk patients. And then just verify that you have a standard protocol in place. That's often one of the quickest things we can implement to improve patient care. We did receive your feedback here on what you're hoping to learn more about as we move through. And with that in mind, our next session, we are changing our format slightly. And so we do have an updated registration that we would like everybody to go in and please re-register for the final 3 sessions of this series. Session 2 will be on November 5th. We did move that because we didn't want to interfere with anybody's civic duty and ability to vote. So we will be meeting at a slightly different time next time to allow for that. And as always, please feel free to reach out to us and let us know if you have any questions. You can catch that updated registration link either in the slide deck or Caitlin has put it into our chat. So thank you everybody again for your participation, and please reach out to any of us if you have further questions.
Thank you, everyone. Thanks for joining and all your feedback.
Thank you.
Thanks all. Have a great evening.